people will roll in as we go. As we start, it's fantastic all of you can join us in this webinar. I think, as always, it's good for us to reflect, even though we're meeting from different parts of the province of where it is that we practice. I'm coming from the traditional territories of the Semiahmoo, Katsi, Coquitlam, Kwantlen, and Tsawwassen peoples. Those of you across the province are coming from other areas, and I think it's important to reflect on this wonderful land that we get to enjoy. Otherwise, today, welcome to one of our education webinars, and we're very, very fortunate here to have Dr. Golnar Sajati, who's going to be talking to us about how to promote success in a weight loss journey. Dr. Sajati, aside from being a good friend and colleague of mine, also has advanced training specifically in both obesity and lifestyle medicine, and is board certified from the American Board of Medicine for both of these. She practices at a couple different locations throughout the Lower Mainland, which we'll hear more about when we get to how it is that we can link people in with her. And we're just super fortunate to have Dr. Sajati, who's an expert on this issue that's so common to many of our patients. So with that, I'll turn it over to you, Dr. Sajati, and would love to hear it. Oh, the one little thing I forgot to mention is, as always, we'd love to collect questions, put them in the Q&A box as we go, and at the end, I'll bring those forward. But otherwise, yes, please welcome and thank you for sharing with us here today, Dr. Sajati.
Well, thanks, Mark. Thanks for the invite and thanks for the kind remarks. Thanks, everyone, for joining in today. And let's just get started on talking a little bit about weight management. So our objectives are a review of obesity assessment, treatment options available to the patients, and how to access a specialized obesity assessment, and how multidisciplinary chronic clinic disease staff can assist with ongoing management. So first off, let's just bear in mind that obesity is a chronic medical condition. It's not simple, and it's not working for these patients to tell them eat less and move more and everything is going to be fine. So there are, in fact, evidence-based treatment available for these patients, and let's explore more and learn more about these. So first, to start to do these assessments, I asked about patients' past medical history, medication, social history, alcohol consumption, smoking, family history. But on top of that, it's important to do a little bit more probing into obesity, how the weight issue started, what age was the age that obesity started, how it progressed, what were the weight loss effort that the patient made, what was successful, what wasn't, a detailed history of nutrition and diet, a detailed history of their mental health issues and the anxiety level and how the patient is dealing with that. How they sleep. As we know, insomnia can have effects both on appetite and obesity. So all of these issues can play a part, and we try to get the thorough history from these patients. In physical exam, we also do a generalized physical exam, just like everyone else, but we also focus on the waist circumflex, and that's basically is associated with visceral fat or abdominal fat that then correlates with risk of cardiac condition or diabetes. So in fact, if the waist circumflex is more than 35 inch in a female or more than 14 inch in a male patient, the risk is higher that the ones with even a similar weight and height. So pattern of obesity also matters in the assessment. Also, it's important to be aware that different patients with different ethnicities, these numbers vary, and we do have a chart for that as well. The other factor is body mass index, and we usually calculated that with weight in kilogram divided by height squared, and we would like to assess that as well. some of the clinics, including my clinic, we do also have a body image machine, and that also is useful in particular with patients who are athletes and have done exercises and can give us percentage of fat and body fat percentage in their body. Usually when we look at body mass index, we use that as the 0.5 and 24.9 is normal weight, 25 to 29.9 is overweight, above 30 to 34.9 is stage 1 obesity, 35 to 39.9 extremely obese but a stage 2 obesity, and above 40 is morbidly obese or stage 3 obesity. Here is a slide about waist circumflex, and that one shows how important is not only the weight and height, but also waist circumflex and the risk, cardiac risk or metabolic risk in general. So patients who have body normal BMI, of course, they don't have a risk, although the ones that they're still in normal BMI range, but have, waist circumflex above 1 or 2 centimeters in male or 88 centimeters in female, they are at increased risk. The ones that are overweight, they have increased risk if their waist circumflex is below 102 in male and 88 in female, but high risk if they are above that. Also in the category of obese, as you can see, the risk is high risk if the numbers are below 102 and 88, but very high risk if above that number. So that's the assessment overall, and there are different treatment options as well for these patients. Let's first talk about nutrition and diet. So of course, it's important for patients to decrease the total calories and control food portion, but also to have a healthier diet in general. So food like desserts, candies, fat, processed food include lots of calories in a small portion, whereas if they go with fruits and vegetables and more fiber, they can have larger portions with fewer calories. So overall, I always advocate for plant-based diets, lots of vegetables, lots of fiber, and lean sources of protein. So of course, it's a different for someone who just have a small, bowl of fries compared to a salad. I always encourage physical activity. We would like people to have at least 50 minutes of moderate intensity aerobic physical activity to prevent weight gain or maintain loss. And also, if possible, and if they achieve that, 30 minutes of weight resistant training. So also all notice in our patients that lots of patients are now leading a sedentary lifestyle, especially after pandemic. We want to encourage more and more physical activity, both throughout the day, but also focused physical activity, some dedicated time for physical activity. Mental health also is a big part of this. So lots of these patients look at food as a way of compensation to cope with anxiety, boredom, depression. So counseling can help with these issues for patients to realize actually that is what they're doing and find another way to compensate, to divert themselves and give themselves a break, finding other ways of relaxation. Now, and there's always that chicken and egg issue with obesity. Of course, obesity and weight issues can lead to mental health, but mental health can cause obesity as well, both the condition itself, but also lots of treatment. Many of the patients that we see, they're on antipsychotic, and as you know, a common side effect of these medications is obesity. And that's why it's important to be aware of these issues coming on and address them as we go along. There are also pharmacological treatment with obesity. Of course, this needs to be used with lifestyle changes. We consider this if the body mass index is above 30 or above 27, but with other heart metabolic condition or comorbidities related to weight, like heart disease, stroke, osteoarthritis, diabetes, so that these medications can be considered in these patients as well. One of the treatments approved by Health Canada is Contrave. Contrave is a combination of naltrexone and bupropion. Naltrexone is a medication that uses management of alcohol overuse or opioid density. Bupropion is used mainly for smoking cessation and is also a typical antidepressant. So the combination works in two different parts of the brain and helps with controlling hunger and craving. Now, these medications are generally expensive and not covered by pharmacare. But for this medication, for example, the medication can be prescribed separately, and that way the generic form is affordable for most patients. There are some known side effects associated with these, including insomnia, increasing blood pressure. So it's important to consult patients about these possible side effects. One of the other medication approved by Health Canada is liraglutide, and this is a GLP-1 agonist. This is a hormone that naturally is affecting the appetite and food intake. It is frequently used in diabetic patient. Well, as you might know, these medications came to market initially as diabetic medication, and then the effect for weight loss came up, and now is also approved as weight management medication. Now, they also can have a good impact on waist circumference, blood pressure, or even cholesterol level. One of the issues with using these medication, again, is expense, and unfortunately not covered through pharmacare. So it's usually can be used with patients who have extended insurance or can afford the cost of these medications. Now, semaglutide from the same family of GLP-1 agonists recently approved. I didn't include the slide here just because the medication Wegovy is not in the market yet. I heard news that maybe in September, October might come to the market and possibly more affordable. Of course, surgery is another measure. It can be really efficient in many of the patients, but it's important to think about it as just one tool, not a cure. It should be used especially with other measures like healthy eating habits, regular physical activity, behavioral changes. Now, the way it works is that it restricts the amount of food that can be consumed. So there's that restriction of the calories that enter, but also a situation of malabsorption. And that's why there would be also endocrine changes that lead to weight loss. Weight loss can be about 25 to 35% with these of the initial weight with this procedure, and there will also be improvement with the comorbidities associated with obesity, like diabetes or fatty liver disease. What is important is the eligibility criteria. I often get referrals. Patients arrive in my clinic and they say, "Oh, I did diet and I do want the surgery because I feel that's the best solution for me." Not everyone is going to be approved for these procedures. The BMI needs to be above 40 or 35 medical conditions, including heart disease or high blood pressure, sleep apnea, osteoarthritis or diabetes. Also, it's important that every other measures have tried prior to this, like improving nutrition, regular physical activity, counseling, and permanent lifestyle changes has already been made. There are patients who are not going to be eligible, usually, although not 100%, contraindication, age above 65, not really a very good candidate. And the reason is usually because the wound healing and the recovery after the procedure is not great after that. However, there can be some exceptions to if the problem is only being in a senior age. Smoking, absolutely, patient should be smoke-free more than 6 months before we can consider this. If there is active substance abuse, that cannot be considered. If there are any unstable mental health issues, that this cannot be considered. And usually patients should be 18 minutes, have 18 minutes of stability before this can be considered. If there are medical conditions that increase the risk of the surgery, that of course is a problem. And there is another part that patients should be really able to comply with recommendation and follow directions. I usually tell people that the process to get ready for such a surgery is at least 18 months. So don't expect to come in and just want the surgery in 2-3 months. The wait time for this, I believe enrichment group, is about 3 to 4 years if those preconditionings have not happened in a bariatric clinic. If those conditions are already looked into and kind of optimized, I think they do the surgery, but the optimization of a patient for such a procedure take about 18 months. So I'm just going to talk a little bit about different procedures. So one procedure could be sleeve gastrectomy. As you can see, they remove 80% of the stomach and leave a banana-shaped stomach in size. That, of course, limit the amount of calories that one can digest and promote endocrine changes that can cause weight loss. There's gastric bypass or Roux-en-Y, and with this type, there would be a small pouch from the stomach, and then the connection is made directly to small intestine. This, of course, causes restriction in the amount of calories, but the food will bypass, and there would be a situation of malabsorption, and that can cause weight loss. Biliopancreatic diversion with duodenal switch is another surgery. And with this part, if we'll see here, the first part of duodenum and stomach size will be decreased, then it will bypass most part of the small intestine and then be attached to the last part. With this one, there is also restriction in the amount of food and calorie, but also malabsorption that can cause weight loss. So it's in a way about, who is fit for what intervention. So everybody should have a healthy diet. Everybody should exercise. Everybody should have counseling and improving mental health and controlling anxiety. Patients with BMI above 30 or BMI above 27 with comorbidities can have pharmacotherapy. Patients with BMI above 35 and comorbidities or above 40 with comorbidities can be considered for bariatric surgery if they meet the eligibility criteria. So I guess the next question is how you can access someone. We do have a clinic and we're happy to be of any help. We work mainly in Fraser Health, and I have also a clinic in North Van. We do have 2 dietitians, and they're both obesity educator and registered nurse that work with us. But also, if you go to Obesity Canada, there is a page on locating obesity management, and support in Canada. And then over there, you can find there are two different ways you can find it. The first bar here is a physician who has the expertise to help you out. There are also then another part that shows the clinics that are multidisciplinary and also have dietitians and other allied healthcare that can be helpful. So you can just basically enter the location and find a clinic that can be helpful to you. I think many of you are probably aware of pathways, so you can look at pathways and also look in who is in your location, does obesity care, and what is the wait time, and see what would be the best fit. I think now with virtual care, things are much easier for patients. From my experience, many of the patients who live with obesity are not very keen in in-person visits, and they do prefer to continue with virtual. We usually try to do one session in person and then bring them, continue with virtuals afterwards, which certainly is easier for many of our patients. This is just our referral form that you can find on the website as well. And then it comes to the topic, how can multidisciplinary clinics like Chronic Kidney Clinic help? I would say the first step is to basically ensure that the environment that you're working at is accessible and respectful to all patients, regardless of their weight and size. And it's particularly important because many of these patients have really bad experiences in the past with healthcare system. I did have patients that come to my clinic and they're diabetic, that they need insulin. They end up in the hospital with hyperglycemia and ketosis frequently, but because insulin is causing them to weight gain, they don't take it because they're worried about the attitude they're going to get because of their weight. So that's, I think, number one. Second, please be aware of the issue of obesity. Check the body mass index versus circumflex maybe once a year for these patients. In multidisciplinary clinics, it could be very helpful because I think you do have access to also dietitians, and that's the part that most of these patients have challenges about, because dietitian care is not covered through pharmacare for the most part for many of these patients. And if they can have that, that would make a huge difference in their care. So providing education about the diet, of course. Other than that, many of these patients have issues with mental health, anxiety, depression. So if there are assistance throughout the clinic for these patients, that would be super helpful. And then if you feel you're confident to prescribe medication, please do. If you do need them to be referred to a clinic, please look and find a best fit for them. And then basically just be an advocate to support these patients. Let's just go to this one. I can't say enough about, providing a safe environment, because this is something I see on a day-to-day basis. Basically, let's start with the way we talk to these patients. There could be, like, many of the issues that they're sensitive to, many of the words that they're necessarily sensitive to. So basically talking to them with a language that is respectful and they feel included in it. In a way, if you compare the care that patients with obesity care with the care that patients with cancer or malignancy care, you probably see the difference. These patients also need to be receiving the empathy and feel included and part of their care. Also, small things like, for example, if you want to weigh them, don't do that in public. Do that with courtesy in a private way. Make sure that the office space itself has the capacity to accommodate them, the beds, the chairs, the guns, the blood pressure cuffs, all of that. So we now know that the more anxiety or that we cause, the more weight gain, more cortisol levels. So all of that can help if we basically help them feel safe and feel that they can approach the healthcare system and get help. And with that, I think I finished up a little bit early. I just, if there are any questions, I would love to hear them and address them.
No, thank you so much, Dr. Sajati. That was fantastic. And I can say, actually, this is very highly attended. We've had over 50 people on the whole time. So clearly there's an interest in this talk, which is great. Just a reminder to everybody. So yes, to get questions in, if you type them in the Q&A box there, so not the chat box, please, but the Q&A box, I'll bring them forward to Dr. Sajati. I'll maybe start with one while people are kind of typing in their questions. So one of the common bits of feedback I get from some of our clinic staff is, we like to try to recommend some of those lifestyle interventions, that kind of first tier that you were talking about. But we often get some hesitancy because of some of the comorbidities that our patients have. A lot of them have a cardiac history and things like that. So, specifically when it comes to recommending activity levels, any kind of general tips you might give, recognizing kind of the older, multi-morbid type of patients we see in the kidney clinic?
Of course. So the patients who have comorbidities, if they know they do have, cardiac condition, somebody is usually taking care of that, like a cardiologist or an internist or someone. So I would just maybe communicate with their physician directly and just say, what's the stability of this condition? Is this something we can explore? What I do is I usually always start very slow. Like usually most of these patients basically do no physical activity. So I would just say, start, why don't you start with 5 minutes a day, every day? And then if that went well, maybe 5 minutes twice a day, and then maybe 5 minutes 3 times a day, and then maybe build up from there. So don't start with a high bar and then they probably don't follow. And then also they might have problems and they might get discouraged. So start very slow. And for me, when I see them, when I have concern, I also do a quick cardiac assessment, a physical exam, maybe even a treadmill test. But if they come to you and they have cardiac condition, they probably somebody is looking after them. So I think the key would be communication. Most of the patients, even with cardiac disease or heart failure, they're okay totally to go with 5-10 minutes of a walk and then build up from there. If they're not, of course, if they have a critical LAD disease and they're waiting for angio, then that's a different story. But usually they don't need to be bed rest or don't do nothing. So we do have that capacity to start somewhere and monitor the symptoms and take it from there. But of course, I think the key is to communicate with whoever taking care of the patient in terms of other comorbidities, if it's cardiac condition.
Perfect. Those are both very practical tips. That's perfect. Okay, we're getting a couple coming into the question and answer box. And again, a reminder to people, put your questions in there. So one that's been up for a while is to, if there's any numbers you can quote in terms of the success rate of the surgery, and maybe I'd say actually both for the surgical and the, pharmacologic interventions, because I think a lot of people have it in their heads that the surgery is this 100% type of thing, but maybe, some kind of comparison there.
Of course. So, first of all, in terms of numbers, if you do lifestyle, it's usually about 5% weight loss. With you add medication, it's probably another 10% on top average. With surgery, probably about 25%. But I think the key is patient selection. And if you have the right person, the success is high. And that goes back to how well they have screened before the surgery, how long they spend time with different allied healthcare, like dietitian in particular, how well they build up the physical activity, did they really made, permanent lifestyle changes or not. So I do often see patients went to Mexico or to India, they paid for these procedures privately, they come back, they lose a ton of weight, they gain it all back in few years, and then they're there with a procedure that has been now unsuccessful, and now with also a chronic medical condition, because now they're prone to all malabsorptions and vitamin deficiencies and problems that come with the surgery. So I would say I can't give a number because it's from center to center, and I think with the right patient selection, the success rate can be quite high. However, I think the key is the screening, and I think even the centers in Canada, they become better and better as they go, and not only with how the procedure is done, but also the selection. Because I think, let's say if a patient has, for example, binge eating, so you go do the surgery, they lose lots of weight, but then the weight will come back. So I think the key is actually patient selection and finding the right patient for the right procedure.
And that's perfect, and it kind of answers one of the related questions about the tendency of people to relapse. And if I might just probe on that further answer. So a lot of the patients then who have had the bariatric surgery, for example, will they end up staying with a lot of these pharmacologic options if that kind of takes the edge off, like you said, some of those behavioral triggers and patterns?
So if they gain the weight after the surgery, is that the question?
Or even as to help them maintain. So as you mentioned, somebody who's got, more of a compulsive or binge eating type pattern, do you kind of use both in concert to try to keep them on the path after the surgery?
So the binge eating itself is a mental health disease. So if somebody has binge eating, unless that is treated and is stable for 18 months, they won't be eligible to go through surgery, basically. However, let's say if they have gone and it actually unfortunately happens frequently, they've gone and paid for it and outside the Canada, and now they return and they have their weight gain now and they want to be treated. So then we go back to those basics that should have been addressed prior to. If they have binge eating, that needs to be treated. If there are pharmacological treatment that we offer other patients to these patients as well, and we'll try to help the situation.
Okay, now a couple of questions are coming in about coverage, and they both, I think, are along a similar line here. Specifically, why don't I ask two just separate questions? So one, are there any opportunities for coverage of some of these pharmacologic options for people? The question's coming up about people who are either nearing or going to be assessed for a kidney transplant, because this actually comes up often in some of our patients as a condition that they'll be listed or activated for a kidney transplant, which of course is, for a lot of our patients, that dramatically alters their long-term outcome. Has there been any success in terms of either obtaining coverage in situations like that, or any strategies people might follow?
I don't think there is anything necessarily pertinent to a chronic kidney problem. And I think there would be a role to advocate for these patients if that's what you see. Well, what we do in general, and this is a problem with many of the patients, because here or there it will affect something. It's either orthopedic surgery that they need, or a transplant, or something else. And these patients do really benefit from pharmacological treatment. So if they're diabetic, so there is a special authority that can be obtained, then we can use Ozempic. Ozempic currently is not is semaglutide, which is approved with up to the dose of 2.4. You can get coverage for Ozempic semaglutide up to the dose of 1 milligram if they are diabetic and meet the eligibility criteria. And that's either they have to use metformin plus glyburide in the past, or metformin and insulin. And if your kind of patients, if they're really end-stage renal disease, metformin is out. So as far as they have used one agent, hopefully we can get, they can meet the eligibility criteria and get it. Contrave, I think the best option would be to use them separately. So prescribe just naltrexone and bupropion separately, and that would be cheap and patient can afford.
Perfect. Oh, that's a good tip. And you specifically were mentioning semaglutide as well. And is there any role of the older agents like liraglutide or anything like that, or is it just not?
It's just more expensive, right? So liraglutide, Saxenda costs about $250
because it's every day.
And semaglutide is about $250 per month. So it's even if they are going to pay out of pocket, it's better to go with semaglutide. I notice is that most insurances cover Saxenda were better if they have extended insurance. So it just depends on each patient, basically.
Okay, perfect. Great. I mean, right now, that's all the questions that have rolled in. One that I haven't seen come through that maybe I'll just ask, we do have dietitians in our clinics and a lot on the call today, actually. So I didn't see this come in, but, our dietitians are often focused a lot on those things that we have to do with related to chronic kidney disease, but in some cases is onerous enough, like when we get to phosphate and potassium restriction, it's already quite limiting. As far as things they can layer on top of that to help with someone's, weight management, any of kind of the lowest hanging fruit, so to speak, some of the big ticket items that you might suggest that they kind of think about?
So I think the dietitians are really expert in the area, but I think usually what I would say is what we advocate more frequently is just overall go, plant-based, go a smaller portion, stop where you feel full, listen to your internal body cues, add more fiber, usually add more protein, and try to decrease the amount of carbohydrate. And that's all, just basic. But I think you'll be surprised how helpful it is to just bring it up and talking to patients each time. Many of these patients, although they come in and they say, I know it all, I talked to 10 dietitians in the past, but when you start, you realize that lots of this information they have forgotten about, or they don't necessarily pay attention to. The other thing we always talk about them is to how to read labels and all that, and I'm sure you work with them. So I think one good tip would be to just also look at the calorie intake, and all that.
Yeah, that's a good point. Because we do focus a lot, as you imagine, on labels, but more so to do with some of the, sodium and things like that. So that's great that you find a lot more of those general tips rather than having to, work out some specific caloric deficit or something like that. You just focus more on those bigger categories and themes.
Yeah, I think it's very difficult for the patient to keep up with, so many calories per day, do especially like that. Many of them come to us asking for a meal plan, and there's no evidence behind that, just because it's not sustainable throughout. So it's better to do just let them just adhering to a particular diet per se or number of calories per se.
That's great. That fits in a lot with a lot of the self-management we try to incorporate too. The same thing, and I'm sure dietitians will say the same. A lot of patients come asking for a meal plan, but it's more about teaching them to do this. I think it's fantastic.
Yeah.
Okay. One more question that's come in. This is a good one. So in terms of when you're using pharmacologic treatments, do you find that this ends up often being something that people need to stay on in the long term? Or do you find in more people that it tends to be almost like a bridge until they really start to incorporate those other, lifestyle measures? What's been your experience of that?
Yeah. So the way I think about that is what we say in we know is that obesity is a chronic medical condition. So it's just like having high blood pressure. So it's not, lack of willpower or anything like that. So if we think that this patient metabolically have a problem, then they need ongoing management of that. So they do need ongoing pharmacological treatment. That's the way I usually word it for the patient. I say, this is just like you do need thyroid replacement all the time, you do need treatment for this all the time. And I did have few patients in my practice, I should say, that they used it as a jump start and they have been successful keeping their weight down with just like the style measures. But for the most part, and what is research-based and evidence-based is that there will be weight regain after you stop the medication. So this is more of a, long-term situation, long-standing treatment using these medications.
I like that. I like that analogy of blood pressure and blood pressure medications being something I would say very, very close to home for all of us on this call. That's great. Great. I mean, that's all the questions that have come in. I'm not sure. Is there any other points that you'd like to mention that you didn't cover, or any other take-home points you want to leave us with?
Not really, no.
Otherwise, I just want to thank you again, Dr. Sajati. This was fantastic. And again, I'm not just saying this, one of our more highly attended, talks, which shows the interest there. I really, really appreciate it. We'll have the recording up online, usually within a couple of weeks, so that people can access that and take another look again. But otherwise, on behalf of everyone on the call, thank you so much, Dr. Sajati. It's a fantastic session for us.
Thanks a lot for inviting me.
Okay, great. And thanks, everyone. And we'll do this again. Our next one, I believe, is coming up a little bit later in the year. We'll send the calendar out for that.